was awesome. I'm going to give you a little bit of a perspective from my story as a clinician, because I think as we've talked about yesterday and even through today a little bit, it's important to know where you come from as a clinician and your story that you bring into the encounter and the interaction with a patient. I've trained in physical therapy. I graduated physical therapy school in 2003, and then it was endless pursuit of the alphabet soup. I wanted to be a Jedi manual therapist where I could just watch a patient walk and diagnose a facet issue from across the room, or just wiggle a joint and just, fix people like they were cars, like we used to treat people, and unfortunately still do today. In my manual therapy training, I went into fellowship training, which was a great experience, and that's where I thought I was going to really culminate my skills and become just that Jedi manual therapist. And of course, it was great training, great clinical reasoning, and I still use manual therapy, so I'm not trying to bash manual therapy here today. But my encounter with pain science in a pain science course is what really changed my course of my career, because I still recognized as I was getting all these great skills in manual therapy and clinical reasoning, there were still people that were failing despite all these great skills I was having or thought I had at the time, and still fail with a strict manual therapy only approach. And I think we've learned this weekend that we need to hear the experience of the patient and not pull them into our story, a manual therapy story or a strict massage therapy type story or whatever backgrounds we have. So again, it's important to know our story. A little bit about me personally. Those of you who follow me on social media probably have been inundated with pictures of my daughter, Evelyn. She's 6 months old. She's been the best thing that's happened to my wife and I, Mallory. Mallory's a physical therapist in the ICU, so she deals with a lot more scary things than I deal with. I haven't killed anybody or at risk to kill anybody, thankfully. She does a lot more dangerous type care, but interesting applications of pain science that we won't go into today in her care. As I've been able to interact with a lot of folks in this room, and Gillette has been a big one that I've got to talk to with understanding the patient's experience, I used to kind of propose myself to patients as being an expert. I know what you're going through. I understand pain. I'm an expert in pain. And Gillette really kind of put me in my place. I heard her talk about it. She said how kind of insulting that is to a patient to hear that from a clinician, to say, I understand what you're going through. I mean, some of the stories we've heard this weekend, and I'm sure stories you've all heard in your clinical practices, the only person that really has expertise in their pain is the person experiencing it. And I think too often we try to ascribe that we're experts to their experience. Now, we can be experts in trying to best understand and walk with that person through their experience and do our best to kind of, integrate our expertise of understanding pain and things with their experience. But too often we try to ascribe expertise and again, enforce our story and our narrative upon the patient. So I think we can do better in that route. But if we look at the neuromatrix model, and this comes from a Katz and Melzak article that you're probably all very familiar with, this is kind of the best model we have. I know we can argue and talk, there's probably more to it than this, but this kind of really encapsulates the human or lived experiencer. And then what we think about is, well, what does healthcare give us? Healthcare gives us a bunch of people that categorically, to understand a patient and understand a field, we kind of cordon ourselves off into a very narrow body of knowledge, which again gives us ability to understand that narrow body of knowledge. But unfortunately, humans don't work that way. Humans are all encompassing. They are this, they are not that. But again, an example of this, I worked in a very big health system and had a patient who had widespread pain that started with a foot injury and had various things, but she came to this health system that had multi-specialty abilities to specialize in all these different things that you're seeing on the screen today. And I looked at her chart from a 90-day period. She had encountered our health system 75 times with different, and some of these were phone visits, I'll have you, but 75 times where nobody was putting these pieces together for her. They were all seeing her at their little island of, you're going to go see the immunologist, and you're going to go see the endocrinologist, you're going to go see the pain physician, you're going to go see all these people. And it was so hard because I tried to educate this patient on how this all goes together. It's all one human experience that, yes, cordons itself off into different parts of that experience, but you get them pulled into different diagnostic categories and different things where they would still get labeled, and not really seeing the big picture. So it's a hard system that we're working against. Obviously,